give a welcome to Dr. Lupica. Thank you.
So thanks for coming out tonight and supporting LakeHealth. I'm happy to be here. I actually grew up in Mentor, so I'm a local. I work for Lake Orthopedics Associates here in the hospital and also in Mentor. And my specialty includes foot and ankle surgery. I treat most of my patients conservatively unless they need surgical intervention. Most problems can be treated with conservative care. Hopefully you guys can take away a few interesting treatments and thoughts from the lecture tonight. So we'll get started. Some of the topics that I'm going to address tonight include plantar fasciitis, Achilles tendonitis, flat foot deformities, stress fractures, arthritis of the big toe joint, bunion deformities, hammer toe deformities, and ankle sprains. So plantar fasciitis, also known as heel spur syndrome or heel pain, is one of the most common things that I treat on a daily basis. Plantar fasciitis is an inflammation of the plantar fascia where the fascial band inserts onto the calcaneus. The plantar fascia runs from the heel bone to the base of the toes, and a strain over time can cause inflammation within the tendon sheath, causing heel pain. The most common symptoms that patients come into my office and tell me is that I have heel pain, which is worse with the first step out of bed in the morning or after extended periods of rest. If you're sitting in a chair and you go to get up, you experience a sharp stabbing pain in the bottom of your heel. Sometimes it is alleviated with walking and stretching, and clinical examination generally reveals pain with direct pressure to the insertion of the medial band of the plantar fascia. Sometimes there is an effusion or a localized swelling in the area, and generally there is also a tight Achilles tendon associated with this problem. The treatments for plantar fasciitis, 95% of people can be treated with conservative treatment options. And I have a basic algorithm that I follow for these patients, which includes a stretching program, which you can see here. All of these stretches are focused on stretching the Achilles tendon as well as the plantar fascia. Some people have used a tennis ball trick. I like to have patients take a water bottle and put it in the freezer, and they can use that to roll their foot across it on the floor, and that helps to both stretch the plantar fascial band as well as ice the area at the same time. Taping, most of my patients I tape in the office, and the taping will not only support the plantar arch of the foot, but it will also mimic what a custom or accommodative orthotic would achieve. A night splint is a soft boot that you can wear at night, and the night splint is very effective because it provides a passive stretch of the Achilles tendon while you're sleeping. When people are sleeping, their foot is generally in a plantar flex position, allowing the Achilles tendon and the plantar fascial band to contract. And that is why you have pain when you first get out of bed in the morning, because you actually have contracture of the fascial band, and when you initially step down, as your arch spreads out, it pulls from the insertion of the plantar fascia, causing inflammation and tearing. Generally, the best shoe to wear with plantar fasciitis is a tennis shoe or a supportive walking shoe. And most of the time I will have patients get an accommodative orthotic that they can purchase over the counter. Sometimes if that is not offering enough support, or if a patient has other deformities of their foot and they need a custom orthotic, I will send them to receive a custom orthotic. Plantar fasciitis generally takes about 6 to 8 weeks of treatment before the pain is resolved. And it can often take longer than that depending on how long you've had heel pain without treating it. A lot of the patients in my practice go untreated for several months before coming to see me for initial treatment. And that's pretty standard with most heel pain or arthritis. People will try to alleviate the pain without seeing a doctor first, but it may require more advanced treatment, including steroid injections, physical therapy, and sometimes surgery if the pain is chronic. Achilles tendonitis or tendinosis is pain that you would get in the Achilles tendon or the calf muscle. And the Achilles tendon is the strongest tendon in your body, and it actually crosses 3 joints. It starts from above your knee, crosses your ankle joint, and crosses your subtalar joint, and inserts onto the back of your heel. Achilles tendonitis is a condition that causes pain, swelling, and if untreated long-term can lead to a potential rupture. Achilles tendonitis occurs suddenly increasing your exercise activity. Some patients will come into my office and say, I started to experience pain in the back of my leg, and I'll ask them what their most recent activity changes were, and a lot of the times they'll say, well, I tried a new exercise program at the Y, or they started a new activity or a sport. Doing the same exercises or activities repetitively, such as jumping, can also cause inflammation within the tendon. Most of the time, before people exercise, they don't stretch. I'm definitely guilty of that myself. Improper or worn out shoes while exercising is also a very common cause. Most people keep their shoes for several months, if not years, longer than they should. There are studies that show that if you walk consistently in the same pair of shoes, they only last about 4 months before their shock absorption wears out. And most people, including myself, do not get rid of their shoes after 4 months. The most common symptoms of Achilles tendonitis are pain in the back of the leg just above the heel bone. Pain usually gets better with rest and worse with exercise. Stiffness or soreness in the back of the leg, especially in the morning. Swelling over the Achilles tendon just above the heel bone, and difficulty standing on the tips of your toes, or sometimes walking up and down stairs may also trigger symptoms of Achilles tendonitis. Symptoms of an Achilles tendon rupture can include a sudden severe pain in the back of your leg. Most patients with an Achilles tendon rupture will come into the office with weakness with plantar flexion, and they generally tell me that it feels like someone kicked them in the back of their leg, and when they go to turn around, there's no one standing there. Achilles tendonitis usually gets better with conservative treatment options, but can take several months to completely heal. Rest, avoiding the activities that cause the pain, will help. Ice, stretching exercises, physical therapy. Most patients in my practice who come in with Achilles tendonitis, I place on anti-inflammatories if they're safe for that individual. I will get them involved in physical therapy with a specific group of exercises called eccentric muscle stretching. They also can have something performed called iontophoresis, which is a safe way to deliver a topical steroid over the inflamed portion of the tendon. I do not recommend any corticosteroid injections into the Achilles tendon area because of rupture. I have several patients in my practice who have had injections into their Achilles tendon from other physicians, and I highly recommend against that. Stretch before exercising is probably the best way to prevent Achilles tendonitis. As you get older, you tend to lose the elasticity in your tendons and ligaments, and they're generally stiff. So it's a good exercise to perform to stretch for at least 5 to 10 minutes before doing any type of physical exercise. Posterior tibial tendonitis is also known as flat foot. A lot of patients have flat foot, and it can range from pediatric patients to geriatric patients. Sometimes flat feet can be painful. A lot of times people will go through their entire life with a flat foot problem and never require any treatment, and it's not painful. It's all patient specific, and it depends on the individual. Posterior tibial tendon is the main tendon that's responsible for maintaining the arch of your foot. and it runs along the inside of your leg, crosses the ankle joint, and inserts onto a bone in the midfoot. And over time, because of the position of your foot, this tendon becomes worn. And when it becomes worn, it can have tearing, causing inflammation, which causes pain. What causes posterior tibial tendonitis? An acute injury may cause it, fall from a height. Most commonly, it's overuse. So overuse activity causes generalized stress on the tendon over a period of time. Once the tendon becomes inflamed or torn, the arch will slowly fall or collapse over time. And this is something that's called adult acquired flat foot. You can see on this picture on the right leg, there is no pronation of the heel. On the left leg, you can see the fourth and fifth toes of the patient because the heel is in a pronated position. This is also what's called too many toes sign. It's a diagnostic indicator of a flat foot deformity. Most of the time, I will have patients stand in the office and I will observe the back of their legs. I will also have the patient go up on their toes. And when the patient goes up on their toes, you can evaluate whether or not the deformity is rigid or flexible. If the deformity is rigid, there's generally either a coalition, which is a problem where the joints grow together in the back of the foot, or there is moderate to severe arthritis in the ankle or the subtalar joint. It's more common in women. It's more common in people that are over the age of 40. It's more common in obese individuals. And it's more symptomatic in obese individuals. The more obese you are, the more strain that you're actually placing on your foot and the tendon itself. The most common location of pain is along the inside of the ankle joint. And this is important with the diagnosis of this over other disorders such as plantar fasciitis or tarsal tunnel problems or generalized osteoarthritis. So the physical examination is important in the diagnosis of posterior tibial tendonitis. Conservative treatment options include low impact exercises like biking, elliptical, or swimming. Ice, no heat. Heat will cause inflammation. Non-steroidal anti-inflammatories if they're safe to take for you. Immobilization in a walking boot or a lace-up ankle brace. A lot of times most individuals respond well to a lace-up ankle brace or an accommodative orthotic in their shoe. Physical therapy is also another effective modality in treating posterior tibial tendon dysfunction, and that would include strengthening exercises, ice, range of motion exercises, and strengthening. Surgical treatment for posterior tibial tendonitis or flat foot has a wide scope of options depending on your age, your activity level, the amount of arthritis associated with the dysfunction, and it will depend greatly on the severity of how torn or collapsed your foot is. There are two types of surgeries that I perform for patients with flat foot deformity. They are either joint destructive or joint sparing. Most of the time, individuals require a joint destructive type procedure, which would be a fusion of one or more joints in the rear foot. The joint preserving procedures are generally performed on individuals who are young. So sometimes kids will come into the office with flat foot problems, and the recommended treatment for them is a joint preserving procedure where you don't involve the cartilage or deform the cartilage in these patients. You can do tendon debridements if it's a very mild case of tendonitis. Fusion of joints, again, is most commonly used in my practice because of the predictable outcome of the surgery. Stress fractures are also common, especially this time of the year when we're most active in Northeast Ohio. And stress fractures occur from repetitive trauma to your foot. A lot of patients who come in with swelling in their midfoot or an aching type pain. Some people state that it feels like a toothache in the middle of their foot. And a lot of times the diagnosis of stress fractures can be made with the subjective examination. They'll tell me that they recently went on a trip or a vacation where they were doing an extended amount of walking or standing. A lot of times this is caused by a pair of shoes that are not supporting the arch of your foot, such as flip-flops or sandals. They most commonly occur in the second or third metatarsals in your foot, which is right in the middle of your foot behind your second and third toes. Osteoporosis can also give you a higher incidence of stress fractures. Pain with weight bearing, pain with increased exercise, and tenderness to touch. A lot of times patients will present to a physician's office with midfoot pain, and that physician will take x-rays. And the physician will tell the patient, I don't see any stress fractures on your x-ray. There's no fracture, just rested a few weeks and it will get better. And by the time they come and see a foot doctor, we will repeat the x-ray, which will reveal the stress fracture. X-rays do not reveal stress fractures for approximately 2 to 3 weeks after the initial injury occurs. Treatment for stress fractures is strictly conservative in 99% of the patients, and offloading that foot with a post-op shoe or a walking boot or a cast is the most effective treatment for stress fractures. Hallux limitus, also hallux rigidus or arthritis of the big toe joint, is another common problem with patients in my practice. They will come in with a painful bump on the top of their big toe joint, and some patients will misdiagnose the problem as either a gout or a bunion deformity, and this is actually arthritis in the big toe joint. There is generally pain with propulsion and toe off, so patients complain of pain if they go up onto their toes. Pain is usually worse with barefoot walking and alleviated with stiffer soled shoes. Radiographic evidence, there's multiple stages of hallux limitus or rigidus. As the problem gets worse, you develop more and more arthritis within the big toe joint, and you can see the big toe joint becoming more flat. The head of the first metatarsal is generally round, and as the deformity increases, flattening of the joint occurs. Also, there's 2 small bones that are underneath the big toe joint, and a lot of patients ask me what these are. These are sesamoid bones. They glide within a tendon underneath the joint, and you develop arthritis or arthrosis of the sesamoids. That's one of the early clinical indicators of big toe joint arthritis. Over time, you can see that there's virtually no joint space available at this point. Most of the cartilage has begun to erode within the joint. And eventually you end up with an appearance like this, where there's essentially no joint space left. This joint is essentially fused. You can also see the large spur on top of the joint in this x-ray here. A chylectomy is a joint preserving procedure that you can offer some patients with mild to moderate big toe joint arthritis. And what a chylectomy is basically cleaning up the spurring around the joint, improving the range of motion within the joint, and is very effective for some individuals. You can have cartilage replacement surgeries where they take cartilage from a cadaveric bone and replace it into the joint. This is called an Oates procedure. You can have an interpositional arthroplasty where you take a band of tissue and place it in between the big toe and the first metatarsal. You can have joint resurfacing, which they make hemi implants. I don't perform a lot of these in my practice because they generally fail long term. Arthrodesis, which is a fusion of the big toe joint, is probably the go-to procedure in my practice if you have moderate to severe arthritis of the big toe joint. Arthrodesis involves removing the remaining cartilage within the joint, placing the 2 bones together, and fixating them with plate and screws. This is a very effective, long-lasting procedure. It's permanent, and it offers pain relief and the ability to bear weight early after surgery. With the common techniques we have with plate and screw fixation, most of my patients are weight-bearing in 7 to 10 days after the procedure. And that's what a plate and screws would look like traversing the joint. The goal of the surgery, if you need surgery for this problem, is to alleviate pain and early weight bearing. Bunion deformities. A lot of patients come into my practice who have a bunion deformity, whether it's painful or it's not painful. And most of the time, patients will say, you know, I have this bunion deformity, I've had it for my whole life, it's not painful, what should I do about it? And my philosophy is, if it's not hurt, don't fix it. Okay, so some of the worst outcomes I've seen are bunion surgeries that did not go well the first time. And patients will come into my practice and say, what am I going to do with this? I wish that I never had the surgery. What can we do to fix this? So if you have a bunion deformity and it doesn't bother you that often, I wouldn't fix it, okay? When is surgery indicated? Surgery is, hopefully you don't have feet that look like this, but when is surgery indicated? It depends on the degree of pain that you have with the deformity. It depends if you're able to put shoes on or not. Sometimes patients come in, they don't necessarily have pain, but they can't find any shoes to wear because their deformity is so large. Does the deformity affect your activities of daily living? That's the best question, and that's the most reliable question that I ask people when determining whether or not they need surgery for this problem. If it affects you on a daily basis or prevents you from doing something that you enjoy doing or used to do, then surgery is probably a good option for you. There are two types of procedures that you can perform for bunion procedures, okay? They are joint sparing or joint destructive. In my practice, I only perform 3 to 4 different types of procedures for bunion deformities. In the literature, in the medical literature, if you look at, there are probably over 50 different types of bunion procedures that have been performed over the last 100 years. I perform essentially 3. So when you look at this foot, look at the x-ray of the foot, you can see that you have the first metatarsal is angled toward the inside of the foot, causing the big toe to rub against the second toe. The apex of the deformity, generally, is at this joint right here. And for large deformities, fusing this joint can realign how the entire architecture of the foot looks, especially the big toe joint. This is called a Lapidus type procedure. The joint that is fused in this procedure is a non-essential joint, meaning that that joint did not have range of motion in it to any degree that you would notice prior to the surgery. So fusing that joint does not affect your gait pattern or your activity levels post-operatively. A joint sparing procedure would be called something along the lines of an Austin or a chevron bunionectomy, which is by far the most commonly performed bunion procedure that foot and ankle physicians perform on a daily basis. This procedure is for someone with a low to a moderate deformity. This procedure does not fix all types of deformities. When patients have recurrence of bunion deformities, it's generally because the wrong procedure was done the first time around. So the go-to procedures in my practice are a fusion of this joint, a fusion of the big toe joint, or a chevron or Austin bunionectomy if the deformity is mild. Hammer toe deformities. a lot of patients who have hammer-toe deformities that come into my practice, and they have several questions regarding hammer-toe deformities. Again, hammer-toe deformities are very similar to bunion deformities. A lot of people, especially in this room, probably have some degree of a hammer-toe deformity. It depends on whether or not the deformities are painful, whether or not you should do anything about it. Most of the time, patients can alleviate a hammer-toe deformity with changes in the shoes that they wear or padding of the areas. Sometimes patients come in with pain directly behind their second toe on the ball of their foot. They have a sharp stabbing pain on the ball of their foot, and this is generally caused by an underlying hammer-toe deformity or an elongated second metatarsal or a short first metatarsal. They're all related. Surgical techniques for hammer toes. Again, there's probably 50 different types of procedures that you can perform for a hammer toe deformity. In my practice, I try to do minimally invasive incisions, such as this one right here. The problem with hammer toes, with making a large incision, is that the toes have swelling for a significant amount of time post-operatively. In the past, the traditional way of fixing a hammer toe is to put a pin through the toe that sticks out the tip of the toe to hold the toe in position while the ligaments and the bones fuse together. In my practice, I like to do what's called an all-inside technique, where there's no exposed wire or hardware post-operatively, where you can fuse the middle of the joint together with a pin or a screw. Ankle sprains. Ankle sprains are the most common orthopedic injury that comes in on an annual basis. I read somewhere where there is over 1 million inversion type ankle sprains that occur in the US every year, which is an extraordinarily large amount of injuries. Inversion ankle sprains occur when you twist your foot or roll your ankle, and generally there is tearing of the ligament on the outside of the ankle. There's a ligament that crosses the ankle joint called your anterior talofibular ligament, and it's the most commonly injured ankle or ligament in inversion ankle sprains. Another ligament that can be injured is called your calcaneofibular ligament, and that runs on the outside of the ankle joint. There are different degrees of sprains, and they are all based on the amount of instability or weakness that you have after the injury. Most people with an inversion type ankle sprain treat the problem with conservative treatment options. Most people who treat inversion ankle sprains don't rehab their ankle properly after the injury occurs. 50% of people who have inversion type ankle sprains have a repeat injury in the future. And that's because the ligaments on the outside of the ankle, if not properly rehabbed, become weak or develop laxity. There is a simple test that I perform in the office. If you have an ankle sprain or you have chronic ankle sprains, that I do to see how much tension the ligaments have on the outside of the ankle. If you have a moderate degree of instability, generally physical therapy, bracing, or surgery is indicated. If it's an acute injury where it's never happened in the past, you can generally get away with ice, anti-inflammatories, ACE bandages, and some therapy exercises. If you do require surgery for chronic ankle sprains or chronic ankle instability, it's generally a repair of the lateral ankle ligaments. You can either do an open procedure, which is the picture on the left, where an incision is made on the outside of the ankle joint, And this involves placing anchors into the fibula, which is the long skinny bone on the outside of the leg. And connected to the anchor are sutures, which you can repair the damaged ligament with. Another technique that has started to emerge is what's called an arthroscopic repair or arthroscopic Brostrom procedure, where you are basically performing the same procedure as the open procedure through an ankle scope, where it's minimally invasive and there is less recovery time. Again, conservative treatment options for inversion ankle sprains is generally the most accepted practice for 90% of people, okay? Physical therapy is probably the best way to rehab an injured ankle. And I try to convince most of my patients to at least go to 2 or 3 therapy sessions, because they have different modalities available that you simply don't have at home. One of my favorite options is this device right here, which is called a BAPS board. And it's a balancing board with a ball on the underside of it, which allows you to develop proprioception and strength of the lateral ankle ligaments. Patients often ask me, what is the most effective way to ice your foot or your ankle? And simply put, I tell them to take a bucket or a large Tupperware container, fill it half with ice, half with water, and submerge the entire ankle or foot into that for 20 to 30 minutes. And that is definitely the most effective way to ice any injured area. That's how professional athletes ice and professional sports trainers. The only contraindication to this is if you have diabetes and you have neuropathy of your feet and you can't feel when it's too cold, and you can actually develop frostbite. So I always consult with your physician prior to doing any of these treatment options. Well, thanks everyone for coming tonight and supporting LakeHealth. Hope you enjoyed the lecture.